Five, five, five. Welcome back to another episode of Superhuman Radio. Today is September 13th. It's a Friday, 2019. It's Friday the 13th. And ironically, I feel like I'm doing really good work today on this show. I am a sincere believer, and those of you who have listened to me for the past few years at least, I've said that autoimmunity finds itself implicated in so many chronic diseases of modernity today. And when we talk about the immune system, we're talking about the gut. And inflammation is the, uh-oh, what happened? We lost something here. My camera. Okay, hold on a second. This is back to the broadcast. Oh, I've got my guest on, but I'm not there for some reason. Suzanne, can you see me?
Yes.
Okay. Well, I can't see me. I don't know if the audience can see me either. I'm going to just try some. No. Oh, there I am. Okay, there you go. My mug is critical to balance out the nice looking person on one side. I have to have my mug on the other side. Well, I'm obviously having some camera issues, but it won't stop the show. This is an important show because I believe that autoimmunity finds itself implicated in many diseases of modernity today, and we could not have a better person to talk about this today. I had the good fortune to have breakfast this morning with Dr. William Seeds and his family, his brilliant son, Billy. And I told them about today's show. And Dr. Seeds said, there's lots of doctors out there talking a good game, but Dr. Turner is actually changing lives for people with autoimmunity with peptides. And that's saying a lot because there's a lot of people out there who claim to know what they're doing, but there's not a lot of people who actually are doing the work. So thank you for being here today.
Thank you, Carl.
So you did a lecture at IPS, International Peptide Society Symposium this year that clearly was amazing because you didn't just talk about theory, you talked about application and actual results that you were getting with patients in the autoimmunity sphere. So let's start there. Talk about the presentation you did and how you even came to start to focus on autoimmunity with peptides.
Well, the pathways are really critical. Those are things I didn't really learn about in medical school, or if I did, I sort of skipped over them. The pace is so rapid that you don't really get a chance to dive in and really grasp what's happening. And so now learning about the pathways for maybe the second time and hearing how there are things we can do that influence those pathways makes a big difference. I also see in my practice over and over again patients who are sick but whose labs look fairly normal, whose regular labs look normal. And so trying to figure out a way to heal them was what started me on this journey in general.
Okay, and so peptides are relatively new on the scene. I happen to know that you are part of the mastermind group at IPS. You are one of the physicians that's actually blazing a trail. Instead of just learning, you're actually contributing to the learning process. When did you introduce peptides into working with these patients that seem to have normal blood work but had a lot of really horrible symptoms?
About 2 years ago. So we had, I have several patients who are like that, who I just knew there was something wrong and we needed to fix them. Or I knew they had autoimmune things and we had treated them with all of the standard protocol therapies, things that you would use starting with their gut, starting with even using things like low-dose naltrexone, but either they had side effects or they didn't tolerate, or for some reason they were not responding to standard of care even in functional medicine realm. And so just by looking for another thing to help, I went to, I guess it was an A4M conference where I heard someone speak about mechanic growth factor. And I had a hip injury at the time that I'd been nursing for a while, probably 2 years. So I ran home and figured out how to order the mechanic growth factor and shot myself with it and got so much better fairly quickly. So I decided to pursue the fellowship in peptide therapy with IPS and A4M.
What kind of people do you see? And I'm going to use the word spectrum. I know it's been used in autism, but autoimmunity is one of those things too. Autoimmunity is a spectrum of disorders, from rheumatoid arthritis, fibromyalgia, scleroderma. I mean, the list goes on. And now we're starting to learn that diseases like Parkinson's disease have an autoimmune component to it. So, what do you see the most coming in your door when they are on that spectrum? What types of diseases you see most often?
Well, probably most common is diabetes and prediabetes. I do practice family medicine, but if you think about it, even athletes are in some degree of autoimmune storm because there are immune inflammation storm because of their extreme training that they do. So probably the number one thing I see is heart disease and diabetes, but I have a good smattering of all the things you mentioned. Unfortunately, more and more dementia would be probably number 3, and then Parkinson, ALS. I had a Huntington's patient, some neurodegenerative disease patients in general, even things like patients who are in their early 40s beginning to have decline in memory, beginning to have where they're not functioning optimally at their job. So that's probably my top ones.
So let's go ahead and start and review the autoimmune pathophysiology like you did at IPS. Let's give the audience exactly the full feel for what doctors were taught when you were speaking.
So unfortunately, the spectrum of autoimmunity is multifactorial. We usually think of it as both genetic, starting with genetic predisposition to having disease, and then progressing on through a complex interplay of factors: environmental toxin exposure, personal or emotional stressors, illness or infection. In fact, most autoimmune diseases, if we're specifically talking about the creation of antibodies against self, most autoimmune diseases start with some degree of, or at some point encounter some sort of infectious cause. And we've seen relationships between rheumatoid arthritis and periodontal disease, and this is an infectious component. We've seen Klebsiella related to patients with MS. And so these, or herpes virus related to patients with MS. So most of these have some sort of immune component or infectious component to them that's sort of a secondary trigger. So they start with the exposures that we have, all of us in our environment, and then they become either because of a sedentary life where you're not removing toxins adequately, or because of exposure to an illness and some sort of infection. There's this trigger of this auto amplification of autoimmunity, where it begins as just a normal process that's supposed to save your body or help your cells respond appropriately to trauma or infection. It becomes a place where you instead, your body begins to continue to do that inappropriately, despite the fact that either the original trigger is resolved or because of the storm of chemicals that goes on. So patients are experiencing this chemical storm of, and I heard Betsy talk about it a couple weeks ago, TNF alpha and IL-6 and all of these inflammatory chemicals that get produced appropriately, probably initially. Now they're being produced in an excessive manner and continuing to create, maybe from what used to be a small nidus, now it involves not only your left knee, but your entire body.
And just as a tangential question to this, isn't it a bad idea for someone who has any type of autoimmunity to take anything that boasts itself as an immune booster? I tend to think of if your immune system is attacking you, why do you want to make it stronger? Or am I off base on that?
So that's a more complicated question than yes or no. It depends on what's in that immune booster and what they're trying to accomplish. It's kind of the reason why I like peptides, because you really can focus. I know that this does this pathway, attacks this pathway, or affects the production of these inflammatory cells or chemicals. And so I know this is going to do what we need for you, as opposed to not really knowing what we're dealing with immune booster. But you're correct. There are several, even peptides, you have to be careful with. LL37 is a perfect example. It's a great, there's some great protocols for treating Lyme disease with LL37. It's a pore forming, so it forms a pore in a hole in the wall of the cell, allowing other things to get in. But if you give this to someone, we know that LL37 is naturally produced by patients, but if you give this to someone with psoriasis, for example, they already create quite a bit of LL37, and it's part of their disease process. So you really do have to be cautious. Also, in general, when you're treating patients, even treating bodybuilders, if they have a component of inflammation that is present to begin with, you really want to calm that inflammatory storm before you begin things like growth hormone or even CJC apomorelin or the LR3. You have to be careful with those, because if you're upregulating the production, the biogenesis of mitochondria and or the function of those mitochondria, they're creating reactive oxygen species, which are doing more damage if you start there. If instead you calm the inflammatory storm first, then you can add those on, and that amount of reactive oxygen species that you naturally create through the use of mitochondria isn't going to be a problem for you.
What percentage of people who walk in your door with autoimmunity have obvious, easily identifiable gut problems?
I would say 90%.
Right?
90% for sure. And you have to be none of this is going to work if we're not working on that. That's one of the reasons why I like BPC 157, because it works to start on getting patients' guts healed. So that's one of my original go-tos with most of my patients is starting there. There's so much research in that using treating ulcerative colitis, Crohn's disease, peptic ulcer disease, any of those intestinal inflammatory diseases. Even SIBO, you can get some benefit in patients with those inflammatory intestinal diseases. If we can calm down that primary immune system, we know we can calm down the rest of their body and begin to do things to improve their overall function. But you can't do that until you calm that down first. So it does require all the things you have to do. You have to eat right. You know, if you're putting sugar and wheat and maybe dairy, maybe soy, depending on the patient, if you're putting those inflammatory things in your body, you're continuing to sort of pour water into the tub that's draining out the side. It doesn't really help until you shut that tub off. Then you can start cleaning things up.
Very interesting. So let's go ahead and start moving into the peptides that find their way into your practice, the ones that you see are most valuable when treating autoimmunity, and how they're used in conjunction and dosed and so on. Let's start there.
So most of my patients that I would describe like this, if we're not talking about the diabetes patient,
right?
We're talking about what we talked about before, Crohn's disease, other inflammatory conditions. I'm going to probably start with them using a thymosin and or BPC 157.
Now we're talking about alpha 1 or beta 4.
So I'm going to start with alpha 1. Okay. If I can do all three, I'm going to do all three. Depending on the patient, these are expensive, as we've talked about. And so if you start with all three, you're talking about a big hit, but it's going to be very effective if you start with all three. Mm-hmm. Most of my patients, because they are multiple chemical sensitive, I'm going to start with very low, probably half the dose that I would normally use on an average patient. And I'm going to start with one thing at a time. So typically I'm going to start with thymosin alpha 1 because I know I can calm down their immune storm using that. We're going to decrease their inflammatory chemicals. We're going to get their dendrites and monocytes to stop being this henny penny, the sky is falling chemicals. We're going to get their barking dog innate immune system to calm down and, you know, come inside and hang out. And then we can begin to add other things on. I can begin to address their intestines. I can begin to address everything else. So I would start with most patients with thymosin
alpha 1. Okay.
Right. And depending on the patient, I'm going to start, I'm going to start anywhere from 0.25 to 0.5 or 25 to 50 units on the insulin syringe.
Now that's coming from TaylorMade Pharmacy. It's already reconstituted. Do you have any idea how many micrograms like I remember when we first talked about thymosin alpha 1 a couple years ago on the show, it was recommended to take 1.5 milligrams every third day if you were fighting a viral infection.
In fact, if you're actively fighting a viral infection, I would take it 1.5 every day to twice a day. That's the research with the, especially with the influenza, is twice a day for 5 days, and you should see a big drop in your symptoms.
So there was someone who listened to my show on thymosin alpha 1, and he had a bad case of herpes zoster breakout on his face and in his mouth. And the doctor said it was moving towards his eye and he could lose his eye. And I told him about thymosin alpha 1. He took 1.5 milligrams 3 days in a row, and it resolved itself in under a week. And he said usually when he had those attacks, they lasted months.
When we treat, the research shows if you even treating animals, we don't see a lethal dose. You can give them tons and tons and tons, and there's no side effects and there's no lethal dose with thymosin alpha 1. So I feel very safe giving high doses. We use it in stroke patients or traumatic brain injury patients in much higher doses, and we can give it IV. So these are very safe to give even at high doses.
Okay, so thymosin alpha 1, BPC 157 obviously is a great player in anything gut related.
Right.
And so you would have your patients take that on a daily basis at a prescribed dose. And how long before those two start to show any signs of quelling the autoimmunity?
So it can be as quick as a week. We have an ankylosing spondylitis patient who's gotten significant improvement in her pain within a week, but it does sometimes take 6 to 8 weeks for us to see a benefit. Mm-hmm. And so I'll usually start one, I'll wait a couple weeks, I'll start a second one, like I'll start thymosin alpha 1, I'll wait a couple weeks, I'll start BPC 157. Most of the time they'll have a side effect by that time just because these are multiple chemical sensitive patients. Average person's not going to have a side effect, but they'll have a local swelling or irritation. I'll drop back, drop the dose, proceed again, increasing the dose over time. And then we'll add in something like thymosin beta 4. So TB4 I love for lots of reasons, for myself, for weightlifting, but also for my patients. I love it because TB4 is like the toy box of the train, pieces of train, toy train. And so if you want nutrients and cells healing and chemicals and proteins, signaling proteins to come to your area of damage or disease, you have to have a mechanism for them to move. And so TB4 is a G-actin sequestering, meaning it holds onto those pieces of train track for you to use when you need them. Otherwise, they're dispersed and reused as something else. But if you have TB4 around, it holds them in place so you can lay down those train tracks to get things quickly back and forth. Even mitochondria to create energy for the process of healing requires G-actin train tracks to be set. So it has a lot of other signaling properties TB4 does, and healing by its signaling properties, but its main function is in laying that groundwork for transportation of necessary nutrients and proteins and mitochondria.
Now, is TB4 given also in low chronic doses, or is that something that you go in with a couple big doses and back out? I see a lot of different discussion on different protocols.
So I will do a pretty high dose the first dose, and then I'm probably going to do it for about 6 weeks. Again, depends on what I'm treating. So I have a patient right now that I'm treating with who has some neurodegenerative disease, very young man, had some fairly significant physical and emotional trauma a few years ago, and is struggling. So I am giving him a 6-week rotation of several nootropics, including TB4. Started with a fairly high dose of TB4, and then I'm switching over for him to cerebrolysin, and then I'll use dihexa, and then I'll use maybe epitalin or DSIP or CMAX, and I'm doing sort of a every 6 weeks rotation with those, with a baseline for him of TA1 and BPC 157. Once he was on those for a litlittle bit, I added CJC epimorelin to increase his mitochondrial function, and then we started this 6-week cycling. So for every patient's a little bit different.
Okay, and there's questions coming up. We will get to them. And Julio, we're going to talk about Lyme in just a moment. Sit tight. I used 400 milligrams of dihexa this morning because I've given up caffeine. And I got to tell you, I feel that stuff when I use it. It's amazing.
It's so interesting. Some people
I rub it on my neck, and literally like a couple minutes later, I'm like, oh, why do I feel like I've just had coffee? So, okay, so the leaky gut thing, right? You know, a lot of people in the medical orthodoxy still. I had a doctor say to me, "There's no such thing as leaky gut." I says, "What's GERD?" And he looked at me. He says, "What?" "Well, what's GERD?" I says, "GERD is your food is coming back up into your esophagus, right? Isn't your gut leaking at that point?" And so, you know, I get this. I think it's humorous that, oh no, the gut just can't leak, and that's just nonsense. But rounding back to the question about gut problems in this population of people, are there other things that you do for the gut specifically to help it kind of reestablish or create a more fertile soil for the things that you're hoping to happen with the peptides?
Well, for non-peptide, I'm a huge fan. I don't use a lot of probiotics. I try to recommend people use food, but I'm a big fan of using prebiotic starch. So I like King Arthur. There's several other good brands, but I like using prebiotic fiber. I mean, if I can get patients to do chia and flax seeds, that's a great way to get them things that their intestinal bugs love to eat. I treat them like stray cats. So if you aren't feeding them what they want to eat, they were going to run away. They're not going to hang around. And if you want them to stay around, you got to feed them fiber, which is what they love.
Good. I'm sorry. Good.
That fiber is going to create when the bugs eat it, they're going to create butyrate, which is the primary fuel for your colon cells. So you could eat avocado and butter and get your butyrate, which is my favorite way to get butyrate. But I also know that I need to feed my intestinal bugs. And so I do that with fiber, various fiber sources.
Dr. Satish Rao came on my show a couple of years ago, and he published that study that blew up the internet about lactic acidosis from SIBO, brain fog, aches in the muscles, soreness, weakness, and all that. And so when I had him on the show, I said, "What do you attribute this modern day explosion of SIBO?" And he said, "Well, you know, it's really hard to say." I said, "What about everybody's taking probiotics willy-nilly? I mean, I was taking VSL number 3, 900 billion CFU a day. I gave myself SIBO. I'm telling you, I did." And so, you know, I'm with you when you said, you know, I'm not a real big, I think that we are going to look back a decade from now and go, man, did we get the whole probiotic thing wrong? Because we were literally seeding the small intestine. So I'm with you.
There's one that uses vegetable fibers as the fermentation source. I like that one quite a bit. If I'm going to recommend a probiotic, I recommend that one, but it's pretty rare anymore that I recommend probiotics for patients.
Yeah. Get it from kimchi. Kimchi is a good source. Sauerkraut that doesn't have sodium benzoate in it to kill the microbes is a good source. So Julio Guevara, I hope I pronounced that right, says any peptides that work for Lyme. So you and I talked off the air. Lyme disease kind of has some of the hallmarks of autoimmunity as well. And when you think about it, it is a form of autoimmunity, because initially the tick lays its whatever in you and your immune system goes after it. But then all of a sudden your immune system goes, oh, that tissue in your joints looks similar. Let's go after that. And that tissue in the muscle nerve, and all of a sudden it just starts attacking the entire body. Is that a dumbed down explanation of Lyme disease?
It's a brilliant explanation. The problem with Lyme disease is it's an intracellular bug. So it's going to hide from your immune system, and it takes over the machinery of your immune system and prevents it from seeing it. So there are sort of flags on the outside of our cells that will alert the immune system that something is there. Lyme disease prevents those flags from being posted. And so one of the things I love about TA1 is it reverses that. It goes back and presents those flags again. It does that for cancer cells too, or we've seen in research it does that for cancer cells too. It allows cancer cells will also take over the machinery for alerting the immune system that there's a concern. And so we've seen in, at least in cell culture and animal research, that we can increase that production of the, hey, there's a problem here flag if we use things like TA1.
Interesting.
Mm-hmm.
So let me put this question up by Jeff Clifton. How can a layperson get a bedrock of understanding for peptides? We're going to come out with something. I promise you. I've been working behind the scenes. But more importantly, his next portion of his question is about healthcare providers and why are doctors reluctant to prescribe? No, they're not. They're just not educated. So if you have a physician that you like and you don't want to start going to someone else who's clearly on the bleeding edge of some of this stuff, send them to peptidesociety.org. Or is it .com? Peptidesociety.org, and have them join the International Peptide Society, where they can be trained to prescribe peptides. The information's out there. The average doctor isn't interested in this. The average doctor that's just prescribing blood pressure meds and metformin to his patients and just going through the routine day mundanely, they're not interested in this. But if there's a doctor that that's like, I'd like to know more, tell them to join International Peptide Society and get educated to prescribe.
It's a long, learning when we're talking.
Uh-oh. You know what? We have to take a break anyway, and then we have a question from Melissa Ann when we come back. We're having all sorts of technical difficulties, but here comes Dr. Turner. Okay, we're back. This is great. You're fast, Dr. Turner. Very, very fast on the gun. I appreciate that.
Try.
Thank you very much. We have a question from Melissa Ann. She says, what peptides are good for Candida? So before you answer that question, I'm starting to think that everybody is being told that they have Candida, and in fact they may. I think Candida is one of the culprits associated with protecting children from getting asthma, if I remember correctly.
Yeah.
But if they have too much, then it's a problem. So talk about Candida kind of topically, about your opinion of it, and then are there any peptides that are good if someone has overgrowth?
So we have to remember that Candida is a normal bug that lives in our intestines to some degree. It's not going to be around to a high degree. The problem is you've allowed overgrowth of that, usually by antibiotic use, recurrent antibiotic use, or by if you're under a particular amount of stress. Now your cortisol has caused that sort of increased inflammation in the wall of the intestine. Those bugs love that, and so the Candida will overgrow in response to that situation. So if you're eating too much sugar, and I'm talking not about fruits and vegetables, I'm talking about sugar,
Right.
If you're doing that, or alcohol, we forget about that being a big contributor. So if you're doing that, probably you do have an overgrowth of Candida. The problem with treating Candida is you can't treat the Candida. You got to replace the things that are missing. And so we have to go back to healing the gut lining and replacing the things that are missing. So again, I'm going to say getting those patients to eat properly is probably number one. Working on their emotional situation, whatever that situation is, getting them to set better boundaries with people or work in their lives. And then we're going to probably have them, they're going to start working on their gut. I might start with doing something like prebiotic fiber, trying to get their intestinal bugs to stay around. You're eating it as whatever you eat throughout the day. And so I'm trying to get those good intestinal bugs to stay around. You got to give them foods they like, which is prebiotic fiber. You know, the goal is 35 grams a day. If you're not taking in 35 grams a day as a woman, 45 as a man sometimes, then you're probably not getting enough. And they're easy sources. Any crunchy vegetable, chia and flax seeds, raspberries, the fuzzy shell on a kiwi, you can throw that in your smoothie in the morning. All of those are great sources. And there's a lot that are available powdered.
Yeah, but I think I'm with you on the natural food sources. I think that's the best. We evolved to eat the foods and extrapolate the benefits from it through digestion. There was a study done about 5 years ago that showed acellular carbohydrates, which is basically what you call flour, any kind of flour. Acellular carbohydrates promote feeding bad bugs in the gut. Because if you would have eaten that stuff as a whole kernel, you would have digested it completely differently than when it's been pulverized into what acellular form, and it just can actually be digested inside the stomach itself still before it gets downstream where it was originally designed to be digested.
And here's one of the problems. If you begin, a lot of dietitians and other physicians will tell you, if you have candida, they will tell you that you need to cut out every single carbohydrate from your diet. Well, here's the problem. If you cut out your carbohydrates, again, I feel like I'm repeating myself, you're not feeding those stray cats that you want to stay there. They want to eat that prebiotic fiber, and they need to create that butyrate, which is the fuel for colon cells. So if you are cutting out every single carbohydrate from your diet, you're really restricting your ability to heal from that candida in the first place.
And there's another, I'd just like to comment a little bit more on that line. The things that live in our gut are highly evolved.
Yes.
In fact, if you look at their relationship with us, it's almost like we served them, right? They needed legs to carry them. They needed a mouth to pulverize things. They needed hands to reach and grab them things. And so we are hosting them, and they're highly evolved. So I know people who went keto and they said, oh, all my gut problems went away. Well, temporarily, because those microbes become spores. They go into a state of suspended animation. Fungi can go into a state of suspended animation. Viruses, we know, go into suspended animation. You can have a viral bug on a countertop 6 weeks, and it's just sitting there waiting for something to pick it up and revive it. These are highly, when something can go into suspended animation, this is a level of evolution that we don't have. Think about that. And so when you stop eating foods that cause the problems, you do get relief. But that's just because they're patiently waiting for you to go back and eat those foods again.
Mm-hmm.
So this is why you have to eradicate them, whether it's with peptides or other things. We're going to talk more about it. What I'd like to do is I'd like to take a break. First, I want to plug your practice. So people who are listening to the show right now, if you live within driving distance of Georgia, your practice is located where?
In Roswell, Georgia. I'm about 20 minutes north of Atlanta.
Okay. Do you do telemedicine?
I do.
Does someone have to come to your practice one time in person first?
I think it's the best. I feel like I can get a better idea of what's happening if I see them. Yeah.
Okay. And how can people find you if they want to reach out to you and come see you?
Our website is www.vinemedical.com, and our phone number is 404-446-3600.
We're going to take a quick commercial break. When we come back, I'd like you to talk about some of the cases you've treated and the results that you're seeing using peptides for autoimmunity, okay?
Great.
All right, stay tuned. We'll be right back with more of the Pep Talk.
Okay.
Okay, so talk about some of your success stories.
So probably I have several, of course. One of my favorites is the patient with Crohn's disease who is only 25 years old, and she got restricted down to a broth and yogurt diet only. Mm-hmm. She'd been through everything. I mean, we treated her with naltrexone and glutamine and aloe and marshmallow root and aged garlic extract and multiple Myers cocktails, and she'd been on colostrum, and then we switched her over to the SBI Protect, and we balanced her hormones. She was in quite a regimen of intestinal barrier repair attempts, and she had very little response to that. We were not the first provider she'd seen either, so she had quite a bit. And we at this point, she had gone to GI and was on high-dose steroids, probably 75 milligrams a day of steroids at 25 years old. So she's already risking osteoporosis and tendon destruction, that sort of thing. So it's pretty sad. So anyway, she comes to us with that history, and we put her on BPC 157, started her at 1,500 a day, capsule form. And over about 6 weeks, she began to be able to withdraw her steroids. So we dropped her down to 500 milligrams of the BPC 157 every day. And this is a patient I just treated with BPC because clearly she has multiple allergies, multiple chemical sensitivities. So I just put her on BPC 157 alone. We did that for about 6 weeks. We dropped her down to 500 from 1,500, and she's been able to almost completely come off. I think she's now on 2 milligrams of prednisone. We're slowly weaning her down with the approval of her gastroenterologist, who's of course aghast at what we're able to accomplish. And it's been great. So we're real excited with her. She's been able to add more foods back to her diet. So her first one she added back was broccoli. So she's getting that prebiotic fiber, and she's doing much better now. She's significantly improved. We started her in January. So we're now in September, and she's down to about 2 milligrams from 75 milligrams of steroids.
Interesting. You know what I found increases mucosal barrier production? It's very counterintuitive.
What's that?
Betaine hydrochloride, hydrochloric acid. By lowering the pH of the gut starts to produce more mucus to protect the lining of the gut. And the reason I think that's interesting is because I've been looking at gut problems for a long time now. Because I even think obstructive sleep apnea starts in the gut, and then the esophagus becomes inflamed and the windpipe becomes narrowed, and boom. But I think that a lot of the problems we have today, I've even found certain artificial sweeteners that will raise the pH of the gut, therefore lowering the acidity of the gut. I have a feeling that we do things in today's society, maybe chemicals that are in our food, that almost act like proton pump inhibitors.
Right.
And so they shut down the hydrochloric acid. The hydrochloric acid in your stomach is the gatekeeper of keeping microbes from getting into the small intestine and taking seed. Exactly. So the pH changes in the gut, the opportunistic microbes start to build homes in the small intestine, and they happen to also have an interesting characteristic. That is, they turn proton pumps off to protect their environment. They turn the acid in the gut down, and slowly the mucosal barrier starts to just disappear. When you introduce, and you have to do this in between meals, people are like, no. An hour after a meal, see what you can tolerate. 1,800 milligrams, 3,000 milligrams, whatever. Maybe it's only 1,000. Take some betaine hydrochloride, not a lot of water, just a little bit of water, and just watch what happens. If you're one of these people who belches for hours after the meal, you'll stop belching as soon as you take that, because the undigested food that's just hanging around will become digested, and motility will kick in, and it'll move along. But when you do that, you'll also find that the mucosal barrier of your stomach starts upregulating. And I think that's counterintuitive. It's so interesting. Or
you could eat smaller meals.
Yeah. Or even vinegar probably works as well, right?
Mm-hmm, exactly.
Yeah. I can't eat a small meal. It's just not in my vocabulary.
I think that's one of the things we do in our society too, is eating larger meals. That makes it strong. Mm-hmm.
Yeah, we just push too much down. Okay, what other interesting? So how about, have you worked with anybody with fibromyalgia? That's a big thing for women today.
So with fibromyalgia is sort of a different process, and you're still talking about this inflammasome, this inflammatory problem, and talking about the signaling to the brain. So when you're talking about that kind of patient, I might even go use something like pentosan polysulfate. But again, I'm always with these patients going to start using something either TB4 or TA1 or BPC 157. I'm either going to start with one of those because I want that inflammatory process to calm down. And then I'm going to move on to using something, in that case, like pentosan polysulfate, to get them to decrease their pain receptors going to their brain. In those cases, there's actually some interesting research on using AOD in pain control. And so you may be able to get away with doing 3 or 4 doses a day of AOD in those patients, instead of using pentosan to get their pain under control.
You know, it's interesting. AOD 9604 came on the scene about 15 years ago as a lipolytic. The problem was you had to inject it 3 or 4 times a day to see any real results. But now it's become so much more than just a lipolytic. It's really an amazing fragment for pain management, to protect soft tissue, inflammatory health, to create a more healthy resolving inflammatory response. what about melanotan 2? I know a lot of people don't want to be tan, but doesn't melanotan 2 have some really powerful and interesting properties as an anti-inflammatory when we're dealing with chronic inflammation?
It sure does. And I'll tell you in a minute about my case with my with using AODHA in my patient with avascular necrosis, which is, we think, an inflammatory response as well. But regarding melanotan, it's a great molecule, and in fact, it would be in my first armamentarium if it wasn't for the tanning benefits, side effect, depending on who you are. The problem, of course, some people don't want to get that tanning, and so if you do want that tanning, that's great. And so it's wonderful to use. It's involved in this. It's easy to find any literature on this. The anti-inflammatory, cholinergic anti-inflammatory pathway. This is involving the vagus nerve. It starts with what you were mentioning a minute ago, the alkaline to acidic conversion in the stomach. So starting with alkaline, going to acidic. It's why we eat our salads first. That conversion from alkaline to acidity can stimulate the nicotinic receptors in the spleen, which then goes via the vagus nerve, stimulating the brain. So now we have the monocytes or inflammatory cells, those nighttime barking dogs in the brain that are calming down. Instead of being henny penny and spewing out inflammatory chemicals, oh my gosh, the sky is falling, they become this very calm janitor. The same exact cell can become one or the other depending on the milieu in which it finds itself. And so this, when it becomes the janitor, it takes the trash out. It helps, especially in the brain, helps with removing inflammatory chemicals and toxins from the brain. And so we love melanotan because that's one of its major effects, is this cholinergic anti-inflammatory pathway, calming down the immune system in general.
Interesting. We have some questions we're going to go run through. So Jeff Robinson, and then he has another one where he corrects his spelling. Would thymulin or thymulin be beneficial peptide for those with CIRS? Isn't CIRS a chronic mold problem?
Yes. Exactly. And so you still have to go through all the pathways treating mold that you would normally do, things like binders and other anti-inflammatories. But most of the time, they're going to require you to start with something that's going to dampen your immune system. Most mold physicians will start with something like those resolving mediators that you get from fish oil, or they'll start with fish oil, or they'll start with pioglitazone. You'll start with all of those at the beginning. You could use TA1 as that same factor, bringing down inflammation before you start with the binding. And so that's probably where I would start, is put them on the pathway to getting their inflammation calmed down, and then start them on the pathway of removing the toxins. You have to get out of exposure. This is the problem. You know, in order to get out of exposure, most people either have to move or change jobs.
Yeah, right.
Remodeling is so expensive.
But you know what? But in all honesty, sometimes it's just changing your lifestyle and the foods that you eat, really.
It can be.
Yeah. I mean, a lot of people, if you start to pay attention to the food you eat, you'll find out there's lots of insulting things in the food that you're eating.
Exactly. Especially in blue cheese.
I love blue cheese too. Gorgonzola. I'm Italian, so we like gorgonzola cheese.
Exactly.
So, excuse me. Here's the next question. I'm sorry. Is there a peptide protocol that you've used with patients exposed to toxic mold and active mold in their system? I guess it's kind of a duplicate question of that. And really what you just said answers that. But what about LL37? So
yes,
the first time I ran so I had foot surgery. And when I came out of the foot surgery, I had a toenail mold on a couple of my toes. And they wanted me to take a pill for like a year to get rid of it. And I thought, this is stupid. I'm not going to do that, right? Well, but I just happened to do LL37. I'm sorry, I just happened to do LL37 for other reasons, and that mold went away.
Mm-hmm. So one of the confusions with mold is that you actually have the mold in your system. In your case, you do probably have some sort of toenail fungus. But when you're talking about the inflammatory system that's involved in mold, we're not talking about mold necessarily living in your body. We're talking about your immune response to those mold toxins. So the brain effects and the intestinal effects and the joint effects are all related to the toxin that mold produces. It might be sitting across the room, but if it's spewing out that mold toxin into the room.
And that's so interesting. So it's not inhabiting you, you're just being exposed to it.
You got it. So some people are allergic to mold, and that's a different category of disease. But if you're specifically talking about CIRS, the chronic inflammatory response syndrome, there's a cacophony of peptides that we use. So I'm a fan of the RG3 nasal spray. I really like the VIP. You have to use that later in the treatment plan so you really need a mold specialist who knows how to stepwise treat you, and you got to remove your exposure.
Oh, by the way, I wanted to mention Metagenics makes a great product called SPM Actives, which is just the inflammation resolving mediators that are in fish oil. Great stuff. Are you familiar with it?
I am. It's expensive, but yes.
Yeah, it's well worth it. Let's see here. So this is a melanotan question. Have you ever used melanotan to raise alpha MSH for chronic Lyme and mold?
Absolutely. It's a later stage treatment. It's later in the treatment. Again, you have to remove the mold first, which most people aren't willing to do or unable to do. And then you have to remove the mold toxin with some sort of binder. And this takes 3 months or so. You can be doing things like TA1, BPC157, RG3 in the meantime, because those are all anti-inflammatories that are going to help your brain. But you have to be careful when you get to, you really don't want to treat that alpha melanocyte stimulating hormone until the end of your treatment. You don't want to raise that right away. You want to use the other inflammatory modulators first, and you'll use that. If you use VIP, your melanocyte stimulating hormone will go up. And your VIP should be low if you have CIRS, or most of the time is low if you have CIRS.
Interesting. Very, very interesting. Let's see here. The next question is, I've had some luck with okra pepsin. I don't know, by standard process. Do you have an opinion on it as a gut healing tool?
It's going back to exactly what Carl was saying before. So the okra is mucin, which is the same things that's in aloe. And that slimy stuff that no one likes to eat that's in okra is the same stuff. And so it goes into the intestine, helps create that lining back again. Absolutely. I do think standard process things have a little bit low dose, but most often people don't need a huge dose, especially our multiple chemical sensitivity. You might respond to a very small dose, but that has the, I'm not sure if it has betaine in it or not. I think that product has betaine. I can't remember if it has just the digestive enzyme pepsin, which is a little bit limited. You need a little bit broader spectrum digestive enzymes if you're going to use them for inflammation.
So I did a show. I'm trying to recall what it was, but it was with a gastroenterologist, and during the show, it was mentioned that when you fast, especially for like intermittent fasting, long fast, 16 hours, the body seems to move a lot of toxins into the gut, and that there's an opportunity to take micronized charcoal,
yes,
and with a little water swallow it, and that will actually bind to things in the gut that you want it to carry out of the body. Any truth to that?
You can use bentonite clay. You can use pyrophyllate clay. I think that the Biocidin people make that one. There are several binders that you can use. The one that has the most binding sites is the cholestyramine powder. It tastes awful, but it is available, and it's got sugar in it, so you're kind of a little counterproductive if you can get it compounded, but that's also another. The compounding one is more expensive.
I'm going to go ahead and answer this question. Yes, this video will be on Facebook forever at the Superhuman Radio Network page, so someone can come back later and watch it as a replay if they choose to. And then, of course, if you go to superhumanradio.net, you can listen to the audio portion of this as a podcast. Let's see. I think that's it. I think that's all the questions we have right now. I want to take our last commercial break, and then we'll kind of wrap up the interview, okay?
Okay.
All right, sit tight. We'll be right back. Go to drseeds.com, drseeds.com. Use coupon code SHR and save 20% off your bottle of BPC Body Protection Complex today. Hey, this is Carl. For 14 years, you've heard me talk about CanC eye drops, they being the reason that I do not need reading glasses at night. That's right, baby. We feel good. Doing reps with the weight of the world. I like that one the best. All right, so first of all, we got a couple kudos to put up. Jeff Robinson says, great information. Jeff Clifton says, great show. Bravo. Jeff Robinson has a question. He says, has your clinic looked into any of the peptide bioregulators by Dr. Cavinson? I think he's probably talking about those di and tripeptides like Pinolon and Epitalon and stuff like that.
Absolutely. So they have such great research. All of the research that was done on them was done out of the company that, or the group that makes them. So that's a little suspect to me. Of course, the research is really impressive though, with improving telomere length, improving longevity. So it's hard to pass up the idea of doing it. The treatment is only twice a year, short term, a quick course of injections, and you do it twice a year. We use them for patients who have jet lag or patients who have migraines. I'll use them in a combination with some other peptides to get rid of migraines or jet lag. So they're available. I have a few patients who've slept really well using a very small dose of the epitalon particularly. So absolutely.
I did that whole protocol, 20 milligrams a day for 10 days.
What did you notice?
I think I was a little less stupid. No, I don't know. You know what? This morning we were talking at breakfast about several things, and I am a very extreme person. And so it's hard for me to tell what's working because I'm usually doing a dozen things at one time.
Right.
But when I was on the bodybuilding forums, my avatar, under my avatar, it said 250-pound Wistar rat. And that's how I saw myself. I am the original test dummy. So Jeff Clifton said something. I want to share something with you as well. He says, your viewership goes way up every time you talk about the gut. So AARP did a study a couple of years ago, and they came back that says that 76% of people surveyed claim to have some sort of gut issue. And we have people out there like Larry the Cable Guy telling people when the foods you don't like you, take Nexium. No, man, that's a bad idea. When the foods you like don't like you, don't eat those foods because you are giving yourself diseases. I just talked about this a few days ago. I was at the gym the other day. I saw a girl whose gut popped out right beneath her solar plexus and went back in right above her pelvic bone. And I thought for sure she was pregnant. And then talking to a friend of mine who knows her, it's like, how many months is she? He goes, she's not pregnant. The level of, I see people that are very lean, distended stomachs. And I already know that this is inflammation from, the esophagus to the anus. These people are so inflamed. And that inflammation is leading to disease states 10 years from now. All the people that are looking at today's show because they have autoimmunity issues need to be patient, because while the symptoms may have crept up on you over the course of a year, the inner workings of developing this disorder have taken decades in some cases.
Exactly.
And that's, you can't see, that's what the pharmaceutical companies want. They want you to feel something quickly. So you'll take some crap drug that doesn't cure the problem, but is tantamount to just removing the battery from the smoke detector. The house is still on fire. And you have to be patient when it's the gut. The gut takes time to get sick. It takes time to get well as well. And I want to do more shows about the gut, because I really believe that if we look at diseases in general, and we take out type 2 diabetes and insulin resistance, right? We put that on the side. We look at this spectrum of other disorders that plague our population today. I guarantee you we can track them all back to your gut.
I would say diabetes would be included in that.
Tell me more. What do you think about that?
I think it's an inflammatory pathway. I think it's eating up mitochondrial function. I think our diet and our lifestyle eats up the mitochondrial function of the pancreatic cells. And that's why we end up with this insulin resistance in the first place.
Yeah, so it's just not an overburdening of the pancreas, you're saying.
Mm-hmm.
Okay. Let's see what this next question is. Let me see if I can get to it. Any other peptides not mentioned that have found to be useful? C-Lank, C-Max, Epitalon, DSIP, those are more brain function, aren't they?
Well, I was going to say, remember that most of the neurodegenerative diseases are brain on fire. They are inflammation of the brain. And so if we're talking about treating the brain, then we talk about TA1 and BPC 157. The research in rats about traumatic brain injury, about stroke. If rats are on BPC 157 before they have their stroke or their injury, absolutely. I love using C-Max and C-Lank in those patients because it's not an injection. So some people are resistant to using injections, especially some of your dementia patients would be really resistant to using injections, but they might tolerate a nasal spray once a day or twice a week, which is the typical protocol for those too. And so we will use those in those patients. There's a lot of things we're going to use in those patients. I'm going to use dihexa because, like you mentioned earlier today, The inflammatory process takes over the way the oligodendrocytes with MS or with dementia, with the way those oligodendrocytes are able to make those axons long and branching. And if we can't get them to function that way or to be that way, then you're going to end up with those neurodegenerative diseases. So if we can decrease that inflammatory process and then add the neurogrowth factors that are in things like cerebrolysin or dihexa or even C-Lank, you're going to find that those patients do much better because they're being properly stimulated.
Loretta Tai says, very interesting. Have you heard of MMS sodium chloride mixed with hydrochloric acid for gut health?
I have
not. There's a lot of stuff out there. There's every day. I'm telling you, people's guts are such a big problem that there are products out there that we've never heard of because you just can't keep up after a while. Let's see here. We have another couple questions here. So Jason, let me see this. I'm having a hard time navigating my screen here. Jason Barkowski. I hope I'm pronouncing it right. I'm sorry, Jay. When starting a peptide protocol like TA1 along with BPC, if you had to stop TA1 protocol for a few days due to the prescription delayed from pharmacy, would it be better to wait until you have enough to complete the protocol or go ahead and start both to get the healing process started?
I would first of all say that depends on the patient, but I'm going to always lean towards let's go ahead and get you started because you're miserable. You're not coming to see me because you feel great. You're coming to see me because you don't feel well. So let's get the process started. And we actually keep a lot of them in our office so that I can just hand it to you when you walk out the door. And I'm usually going ahead and ordering another supply when you leave the office for your next purchase because you're going to need it, especially when we're doing a fairly high loading dose to begin with. And then we're dropping down later, that higher initial dose, you're going to need to replace the bottle quickly. So I'm starting you as quickly as I can. And then, so I would suggest that you do go ahead and get started. I think you probably can't go wrong with using BPC or TA1 if you have an autoimmune disorder to start with. I can tell you story after patients doing well with those, even just one of the two of them.
How many of your patients start a protocol and experience Herxheimer and go, something's wrong, I feel horrible, I feel like I've got the flu for the past couple of days?
So you can usually tell who those patients are going to be. That commonly will happen if you start them on something like LL37 too early. But you're going to usually know them ahead of time because they're going to be the patients who can't tolerate perfume smells. They have a lot of food allergies. They have where they go into a room and they can smell the mold in the room. You're going to have, these patients are going to be, they're going to present to you as multiple chemical sensitive. And those are the patients I'm going to start half dose. I'll tell them what the full dose is and I start them half and I give them the flexibility to increase their dose over a certain number of days to weeks. I stay in pretty close contact with them. They all have my cell phone, so they're pretty
and Herxheimer is a real thing. A lot of people think it's hooey, but some of the symptoms of Herxheimer also are you start to run a very low grade temperature at night before bed. You'll just feel lethargic. You feel like people will say, "I just feel like I'm coming down with something," and really what that is, excuse me, is from the rapid die off. Your body is being hit with all of these toxins all at once that would have normally been pooped out slowly by these little culprits, right?
Right.
Yeah.
So it's the breakdown of the cell wall. So it's no longer an intact thing that your body recognizes and sort of knows how to manage. Now you're talking about a wall that's been broken down and you're exposing your immune system to new things, which is why you have to start with the immune modulating things first rather than starting with, like I said, LL37 or something that's going to be, or even something simple like biocidin. You got to be careful about starting those things too high or starting them too early in the treatment progress.
So Jackie Pullum Noah says, "Love you, Dr. Turner." That must be one of your patients?
Hi, Jackie. Yes.
Wonderful, wonderful. Have we missed anything, Dr. Turner?
I would just say that the treatment of the ability to use these in so many ways and in combinations is amazing. So things like using, I have a patient with below the knee amputation who had an ulceration of his leg below the knee.
Right.
And we were able to heal up that ulceration using a combination of peptides, BPC, AOD, and GHKCU in a cream, a topical cream. And he continues to use that because of his tremendous response to that. Obviously, he has lots of other things going wrong if he's having a below the knee amputation. And, you know, sometimes you can get people to make changes in their lifestyle and sometimes you can't. Applications like my favorite is this treatment that we use when we used AODHA. You were talking earlier about AODHA or AOD. If you use it in combination with HA, this healing fragment of growth hormone is held in place by that hyaluronic acid, the hyaluronic acid. You can use that in these inflammatory things like chronic tendonitis, like I think I heard you the other day talking about your thigh injury that you sustained and that your BPC got you better from that. You can use AODHA for that as well. And that's once a week treatment. This patient I have that had avascular necrosis did really well with several weekly treatments of AODHA. And again, we're treating an inflammatory process. We're using that growth hormone to bring things down. In her, I did not start with BPC or TA1 because otherwise she had a fairly healthy life and lifestyle. She came to me with this avascular necrosis injury, and we started immediately with that growth hormone. She did just fine. I added the BPC because of its repair properties, but that was later.
Have you seen tolerance issues with people with severe autoimmunity to BPC? Jeff Robinson wants to know if you've now noticed that people tolerate BPC better when using TA1 first or combined with. It seems that those with severe autoimmunity can have BPC tolerance issues. I would have thought BPC is one of the most tolerable.
You would think so. So I have a patient with MS who was unable to tolerate the oral BPC. That's what we started with in her because I figured that was her primary source. But in fact, when we started her with TA1, she tolerated it just fine. We did TA1, obviously, sub-Q, and we're getting ready because she's been on TA1 sub-Q about 6 weeks. So we're getting ready to start her on BPC sub-Q to see if she'll tolerate that, where she did not tolerate it orally. She might tolerate the oral again, but again, now we're talking about someone who's got a little anxiety because she tried it before and had a bad reaction. So I don't want to put somebody through going through that again if I have an alternate route I can administer. It's one of the things I love about BPC. It comes in a dental paste. It comes in eye drops. So for your corneal ulcerations, you can use it in corneal ulcerations. And
I'm still using it. I used the thymosin beta 4 and BPC 157 eye drops. I had a corneal ulcer. It lasted months. My audience knows about it. I was blind in my right eye.
Terrible.
And there are no imperfections in my cornea. And now I just have a little cloudiness that may or may completely resolve. But I've got a contact lens in, and I'm 20/30 in the right eye now, thanks to those peptides.
Great. I'm a fan.
I had a question in my head. So with BPC 157 will agitate me at night. If I take it too close to bed, I don't sleep as well. One of the things I was going to ask you was, since some of the implications of autoimmunity seem to affect mitochondria, is NAD plus injectable or drip a good idea for these people, or only when they get to a certain point of progress?
Absolutely. And I'm going to follow their lab results. I'm going to look at things like, I'm going to look at the easiest one. I have a lot of patients who still use insurance. So I'm going to look at their MEB, which is the combination of monocytes, eosinophils, and basophils. And we want to see that be somewhere around 10, 8, 7 would be perfect. If you get above 10, we start worrying. This is your barking dog saying my innate immune system is in the middle of the night seeing something that it doesn't like, so it's barking when I see that MEB go up. So I'm watching that MEB to see if it comes down, and once it begins to come down, that's when I'm going to initiate the other therapies. You can use all kinds of markers, TNF alpha. You can use IL-6, IL-8. There's a few labs that'll do that. There's a bunch of different markers that you can use. CRP plus or minus, you can use ferritin is a great one to use to watch this inflammation begin to come down. And that's when you add in the other therapies, when they're starting to get a little bit better and you see their immune response going down. Now we attack their infections with LL37, or we attack their brain function with dihexa or cerebrolysin.
Interesting. So Jeff Robinson said, last question, I swear. MOTS-C for chronic fatigue. What do you think?
So I haven't used it for that yet. I have so far really used it in, but that's where I think it was going to have its best. I think there and diabetes is where we're going to see MOTS-C be its benefit. The initial expense is going to be a difficult piece, but I think over time, I think the problem with it is, the other problem is it's going to not be as quick a response. Your pancreas isn't going to respond as quickly to it as it's going to respond to insulin or other, diabetes drugs, or changing your diet and exercising. And so you're going to have to be careful with taking patients off of their regular therapies. They may not respond as quickly as you expect. It might take 3 to 6 months to see them respond.
So the website, give your website again, please.
It's vinemedical.com.
And you are just 20 miles north of Atlanta.
Yes.
And so those of you who are listening, give your phone number one more time.
404-446-3600.
If you're in the area and you want to stop spinning your wheels, because, so here's the thing. There's all this great information about peptides. A pretty large percentage of it is wrong. And then you also have to worry about whether or not the peptides you're getting are real or not, or if they are even a high enough concentration, or they aren't laced with some hexane or something else that shouldn't be in there. And so if you're taking it into your own hands and you're trying to do this on your own and it's working for you, Godspeed, rock on. But if it's not working for you, you may want to eliminate one of those possible variables by going and seeing a doctor like Dr. Turner, and have her handle it for you and do it right. Because let's face it, you want to be done with this disorder, right? That's the bottom line. And if that is your mission, then you may need some good counseling. And you're not going to find a lot of doctors out there like Dr. Turner. I can guarantee you won't. Definitely not in your own backyard. So reach out to her and let her know you heard about her on the Pep Talk here at Superhuman Radio.
Thank you, Carl.
Thank you. Thank you for being here today, and have a great weekend.
You too. Bye-bye.
Bye. All right, so that's it for today. We have a great show this Monday. We're going to be talking about red light therapy. Hope you can join us for that. Everybody have a great weekend, and we will see you soon.